Welcome, everyone. My name is Chloe Zaire. I'm the director of the Division of Maternal-Fetal Medicine at Beth Israel Deaconess Medical Center, and I'm really pleased to be joined today by Dr. Duffy, Dr. Cassie Duffy, who is a maternal-fetal medicine specialist. Oh dear, I'm frozen. I froze, didn't I? So I'm joined by Dr. Duffy today. Dr. Duffy is a maternal-fetal medicine specialist and the leader in our division for taking care of people with complex fetal diagnoses. And Dr. Caryn Dutton is a complex family planning specialist and the director of family planning for Beth Israel Deaconess Medical Center. I'm honored to be joined by them today and look forward to learning the latest updates in Massachusetts. Thanks.
Thank you so much, Chloe, for that introduction. I'm Cassandra Duffy, and I'm here with Dr. Dutton today. I'm really fortunate that she's joining us for this talk. And thank you all for being here this evening. We're going to be talking about reproductive choice in Massachusetts, and maybe with a little bit of a maternal-fetal medicine focus along the way. And Caryn and I are sort of going to be tag teaming this. Thanks, Caryn. So she's advancing slides. So our learning objectives for this evening are to understand recent changes to Massachusetts law pertaining to abortion, to review options and appropriate counseling for second and third trimester abortion, to discuss Mifepristone uses and address some of the current concerns regarding access to this medication, and then finally to provide some information on local resources. So today we're going to start with a little bit of a historical and national context before getting into the Massachusetts laws and going over the Roe Act. We'll go through options for abortion in the second trimester and beyond, and we'll touch on some special populations in terms of abortion, specifically kind of in the maternal-fetal medicine realm of things. And then we'll end with the updates on Mifepristone and resources both in the BI system and in Massachusetts. So we're going to start off this evening with a case presentation, and this is kind of a relatively common thing in my field that I see, and we're going to return to this case as we talk through kind of options and counseling in the second and third trimester. So this is a 43-year-old patient who's a Gravida 2 Para 1 who presents for the initial OB visit at 20 weeks by the last menstrual period. Because this is the first visit, there's been no aneuploidy or genetic screening done yet in this pregnancy. Of course, you arrange for an ultrasound, and the ultrasound actually redates the pregnancy at about 23 plus weeks. And unfortunately, there are multiple findings on the ultrasound. So there are several neurologic abnormalities, an absent CSP and ventriculomegaly, some soft markers like a choroid plexus cyst, possible abnormal profile, concern for ventricular septal defect or congenital heart disease, clenched hands, and polyhydramnios. And the final impression here is overall, this is quite concerning for a genetic or chromosomal abnormality. So many patients in this position are going to want to know now, that we're in the mid-trimester, what are my options for abortion or what are my options for this pregnancy given the concerns? And unfortunately, the answer to that question depends on where that patient lives. And for many patients has been changing quite a bit over the last couple of years. So I'm going to hand it over to Dr. Dutton now, who's going to take us through some of the historical background and changes to the law.
Thank you, Dr. Duffy. So as Cassie mentioned, we wanted to start with a little bit of context around how we got where we are now. So just to review the past few decades and not the early part of the 20th century, at least. In 1973, of course, Roe v. Wade, the Supreme Court established abortion as a legal right in the United States based on the constitutional right to privacy. And this made abortion care absolutely more accessible and safer because previous to that time, women were dying from illegal and unsafe abortion care. Unfortunately, in 1976, the Hyde Amendment was one of the first restrictions then noted to be placed on abortion care. The Hyde Amendment prevents federal dollars from being used for abortion services, except in the cases of incest, rape, and life of the pregnant person. Representative Hyde wanted to actually completely ban abortion, but his control was over the Medicaid bill. And so he used that as a vehicle to ban what he could. And this, of course, now disproportionately impacts patients dependent on Medicaid for their health insurance and healthcare, and communities that obviously also already face huge barriers in terms of cost of care and systemic racism. In 1992, with Casey, the Supreme Court reaffirmed the constitutional right to abortion. However, it imposed this undue burden standard and allowed states to then start passing restrictions on abortion care as long as they did not present an undue burden to the patient. This led to numerous medically unnecessary restrictions across the country. In 2007, Gonzalez v. Carhart, which was more broadly known as the partial birth abortion ban, criminalized a specific type of abortion care, despite the fact that it was the safest option for some select patients, and it had no exception for patients' health. And then, of course, in more recent years, we've seen some more dramatic changes, not on just little pieces or parts of abortion care. 2021, September 1st, SB 8 went into effect in Texas, which was known as the Heartbeat Bill, and was a bill crafted to very specifically prevent much ability to appeal that law. And that brings us, to this past year. Of course, during the past decade or so, there have also been dramatic changes on the Supreme Court. And despite the fact that over 80% of Americans support some form of legal abortion, in June of last year, the Dobbs decision changed that dramatically. The Supreme Court overturned Roe v. Wade, removing the federal precedent of legal abortion prior to 24 weeks. And so this is the current map of abortion access in the United States. You can see that the states in dark red have extremely restrictive access to abortion or no access to abortion. In orange and yellow, restrictive laws around abortion care, and little islands in New England, Colorado, New Mexico, Illinois, and the West Coast, where there are laws in place that are very protective for abortion access. And we have seen, and researchers and clinicians are actively working on recording and demonstrating the impact of these laws. When Dobbs was decided last year, many of the dark red states had what are known as trigger bans that immediately went into effect, old laws that were in the books. And once the precedent of Roe v. Wade was gone, those laws went into effect, immediately banning abortion. And many other states since that time have passed new restrictions. This has resulted in approximately 21 million persons of reproductive potential in the United States who live in a state where abortion care is no longer accessible. And this isn't the only big change that's happened. All of these smaller restrictions on abortion care, those have been proposed and enacted in states quite dramatically over the past decade and a half. Even in 2023 alone, approximately 2,000 provisions regarding abortion have been introduced in state legislatures. 6 restrictions have been enacted this year, many more the year before. There have actually been 28 that have improved healthcare access. So there are many states still working on trying to improve access. And a great example of that is, of course, Massachusetts. And we're very lucky to live in a state where, for a long time, our legislators, our leaders, our advocates, our patients, and our providers, Dr. Zara being a notable example of someone who's been really active at the state level through her work with ACOG, have worked to protect abortion access. And so the Roe Act, which was passed at the end of 2020, which kind of amazes me, despite everything else that was going on in healthcare that year, we were able to get the Roe Act signed by Governor Baker. And this codified abortion as legal and protected in Massachusetts. It expanded the gestational age limit for abortion. We'll talk about that in the next slide. It also defined a list or requirements for maternal and fetal indications that would allow abortion without any gestational age limit. It decreased the age of consent. So now ages 16 and older can consent to abortion care, whereas those 15 and younger still require consent of a parent, guardian, or judicial bypass, which in Massachusetts is very easy once patients get connected to the right place. And it allows advanced practice providers to perform some abortion care. So in terms of the gestational age limits, this is a little bit tricky. And even in discussions with OBGYNs, and I know there's some non-OBGYNs on the call, can be confusing. So we wanted to spend some more time going into this. And we wanted to clarify exactly what the current law states, which is that abortion in Massachusetts is permissible for any indication if the pregnancy has existed for 24 weeks or less. And when we calculate a patient's gestational age, where they are in their pregnancy, we use standards set by our professional and national organizations of a best obstetric estimate based on ultrasound and last menstrual period. And so, for example, a gestational age of 40 weeks, which we commonly regard as a due date, refers to 40 weeks since the last menstrual period. This is historical in that we didn't have very good early ultrasound for a long time, and that was the best way to date a pregnancy. But if you think about it, the patient's first day of their last menstrual period, they weren't pregnant yet. And so if you look at this chart, I'm very happy Dr. Duffy pulled this together for us. The last menstrual period corresponds to day 0 or the first day of someone's menses. And on day 14 is actually when ovulation occurs, when the egg comes out. Fertilization occurs soon afterwards. But implantation, the pregnancy attaching to the wall of the uterus, which we scientifically defined as when pregnancy starts, doesn't happen until 3 weeks after the last menstrual period. Therefore, if a pregnancy has existed for 24 weeks or less, it's 24 weeks from this day 21, and it actually now is interpreted in Massachusetts as 26 6/7 weeks by our best obstetric estimate. And so again, abortion is permissible in Massachusetts for any indication now, based on the changes in the Roe Act, through 26 6/7 weeks. Now, luckily, or not luckily, but the number of cases that occur in that gestational age range after 24 weeks are extremely limited. But one of the motivations for doing this was based on laws that existed already in other states, including New York, on which this law was modeled. And it allows patients who are getting these late diagnoses and often requiring or requesting additional testing, consults, and results to return, to have a window in time in which to make a decision, rather than traveling out of state for care. So additionally, in July of last year, as part of the Act for Expanding Protections for Reproductive and Gender Affirming Care, we now have this list of the reasons that the indications for abortion after 26 6/7 weeks, or after a pregnancy has existed for 24 weeks, if in the best medical judgment of the physician, it's necessary to preserve the life of the patient, preserve the patient's physical or mental health, warranted because of a lethal anomaly or diagnosis, or warranted because of a grave diagnosis. And the language used was very carefully chosen to make sure that patients and providers have options. If a patient requests abortion at this stage of pregnancy, it should be carefully documented in the medical record which of these indications are met. At BIDMC, we do strongly encourage both clinicians, and the patient to consult with colleagues, with specialists, to get guidance around this decision. Again, the number of pregnancies happening later in pregnancy are very low. And if you look at this circle chart of when abortions occur in the United States as of 2019, the vast majority, the darker blue wedges, are in the early part of pregnancy. At less than 13 weeks of pregnancy accounts for 93% of all abortions performed. So that leaves only 7% that are performed after 14 weeks. And the number that occur after about 22 weeks are less than 1%. At BIDMC, because of the specialists that we have and the training and expertise present in both our divisions of family planning and our divisions of maternal-fetal medicine, we do a much higher proportion of late abortion care, serving as a referral site, both for the Leahy system and now for patients outside of Massachusetts. We've long been a referral center for Northern New England, which does not have access to late abortion care, so that approximately 40% of our surgical procedures are in the second trimester, over 14 weeks. So we're going to return back to our case and kind of talk through for this patient how we can counsel them if they choose termination. And just as a reminder, this patient presented thinking that she might be about 20 weeks by her last menstrual period. On ultrasound, the measurements were more consistent with just past 23 weeks. And at this point, the patient has said, this is actually an undesired pregnancy. I wasn't planning it to begin with, regardless of what things show, and what are my options for next steps. In general, when a patient requests abortion, we are able to offer them either surgical or medical management. The surgical procedure is known as dilation and evacuation, or D&E. The medical procedure involves essentially induction of labor. And so we'll spend some time talking through how we discuss these options with patients. And I think this is particularly important in terms of anybody who's referring patients into our practice, just in terms of helping patients anticipate what types of options are available and what they may experience. If someone chooses a surgical procedure, this procedure does take place over 2 or rarely 3 days. On the first day, they will come in, meet our team, receive counseling. We have a social worker present in clinic, and review the consent forms. They undergo, when they are over 16 weeks, placement of cervical dilators. Cervical dilators gradually work overnight to soften and open the cervix, which significantly reduces the risks regarding this procedure. The more open the cervix is, the safer the procedure is for the patient, but technically easier it is for us. We also often use Mifepristone towards the end of the second trimester. That takes about 18 to 24 hours to work, assists with cervical softening, and is an adjunctive method of preparing the cervix. And for patients who are prior to 16 weeks, so in kind of the early part of the second trimester, we can avoid dilators in most situations by using buccal misoprostol for cervical preparation. So that at least helps avoid a procedure they may not need otherwise. So patients come in the first day, they get their blood work, they go through the counseling, we prepare them, give them information for returning the next day. If a patient is very far along in pregnancy, or if the initial placement of dilators is unsuccessful or limited, they do sometimes require a second set of dilators, and rarely that would be scheduled as a 3-day process. When they return for the procedure the following day, the D&E is performed under IV sedation or general anesthesia in our main operating rooms. That is not a requirement. There are many settings in which D&E is available in the outpatient setting, including at Planned Parenthood and some of the other institutions in the area and in Massachusetts who have procedure units that allow for IV sedation. Once the patient is comfortable in position, the dilators are removed, the fluid is evacuated, and all the pregnancy tissue is removed under ultrasound guidance. There are no incisions or scars from this procedure. The recovery is actually quite quick following the procedure, and within a couple days, they're able to return to their usual activities. So that's how I describe the D&E procedure to patients, and we're going to transition back to Dr. Duffy, who will discuss the process for induction of labor.
Thanks, Dr. Dutton. I don't know, do you want to say a word about the gestational age or size limitations for dilation?
Yeah, good point. Thank you. I even had that written down as a note, but so the limitations of providing the procedure of D&E are really based on fetal size. Once the pregnancy is past 24 weeks, it does become a more difficult procedure to remove the pregnancy through the cervix. And that's definitely when we would think about 2 days of dilators before the procedure day. And so technically that limit is going to be different depending on the institution, generally between about 24 to 26 weeks. If a patient chooses pregnancy termination, it will become an induction procedure. After about 20 to 22 weeks, the risks of these two options are very similar. So for patients and discussing their options, they want to know what's safest, what will preserve their uterus, what will give them the best chance of a safe pregnancy in the future, if that's their choice. And you know, around 20 to 22 weeks, that risk becomes fairly similar. Prior to that time, in general, surgical abortion is a safer procedure, although for some reasons, there are still reasons why a patient or family might choose induction of labor.
Thank you. So I'm going to talk a little bit about induction of labor. And this bullet point here reminds me about the limits for dilation and evacuation, but induction of labor, sort of one of the advantages is that this is available at any gestational age. Like Dr. Dutton said, because there can be more complications at sort of earlier gestational ages, we tend to prefer surgical management, but certainly it's available at any gestational age and doesn't have an upper limit to that. So this procedure, you know, is like any other induction of labor, so very familiar to all OBGYNs, where medicine is given or induction agents to bring on contractions and induce labor. And the type of medicines we use and the specific regimen depends a little bit on the gestational age. So in the second trimester at BIDMC, we use a high-dose misoprostol regimen, generally 400 micrograms, and these can be placed, this can be placed in the cheeks or vaginally per the patient's preference every 4 to 6 hours. And there are similar regimens using doses between 200 and 600 micrograms of high-dose misoprostol. This is a very safe procedure and also can be used in someone who's had a prior low transverse hysterotomy as well safely. The rates of uterine rupture are very, very low in the second trimester. In the third trimester, we use, oh, that's okay. In the third trimester, we use doses of misoprostol that are similar to what we would use in continuing pregnancies for induction of labor, so 25 to 50 micrograms. And then we have all the other sort of medicinal and other tools that we use for induction of labor at our disposal, although often, particularly in the second trimester, we don't need to use anything other than misoprostol, but we can use intercervical Foley balloons. We can do artificial rupture of membranes, use oxytocin or Pitocin, or even place cervical laminaria if we think that might be beneficial for a particular patient. So at BIDMC, at least, these induction terminations occur on labor and delivery. So patients have a scheduled time that they present to the hospital. They're brought into a labor and delivery room with a nurse there who takes care of them. They have an IV placed. They meet our anesthesiology team and have options for pain control, either IV medications or an epidural, whichever is their preference. And then we talk to them about the misoprostol regimens that we'll be using. You can go ahead to the next slide. And then I just want to point out, we also use Mifepristone for cervical ripening before induction of labor, similar to dilation evacuation. And there are lots of studies that show that this is a really useful tool and a really helpful off-label use of Mifepristone. So this is just one small study, and this was looking at inductions between 18 and 23 weeks, and was a randomized controlled trial. So the Kaplan-Meier curve to the left are patients that received Mifepristone about a day before their induction started. In this study, they used high-dose misoprostol, similar to what we use here at BIDMC. And nearly every patient in the Mifepristone group in this study delivered within 24 hours. The median time was about 10 hours, so significantly less than those in the placebo group. Those times would expect it to be a little bit longer at later gestational ages. So for the patient that's 22 or 24 plus weeks, I usually, try to counsel them that this might be, a day or 2 day long procedure. It's always good to prepare people in advance for the longer end of things. And then also really importantly, this group didn't see any differences in rates of significant side effects with use of Mifepristone or rates of retained placenta. So a very, very helpful medicine to give before induction of labor to shorten the time to completion. You can go to the next one. Great. So when I'm meeting a patient and they have the option of both a dilation and evacuation or an induction of labor, which is true at BIDMC for many gestational ages, the most important thing that I want my patient to understand is that both of these procedures are safe and effective. And try to provide the counseling about both options in the way that Dr. Dutton explained it for dilation and evacuation, and then also walk them through induction and really just advise them to make the decision based on their personal preference, whichever experience they think would be more desirable or less undesirable, because oftentimes they might not be wanting to go through either procedure. Some of the advantages of dilation and evacuation, in some sense, there's a faster time to completion and some predictability around the procedure. When it's going to be scheduled and it'll be completed relatively soon thereafter. At least at the later gestational ages, most of those occur under general anesthesia, which might be preferable to patients. And overall, in terms of surgeries, it's a very safe and very low risk procedure. Some of the advantages to the induction of labor is it does avoid surgery for patients where that's a strong preference, and it also avoids the need for an earlier visit for cervical dilation or laminaria placement. Although if we can, we'll try to see them the day before to get them the Mifepristone, but that's just a pill you take by mouth. For some patients, they might, have a desire to go through the experience of labor and to be awake for that. For other patients, that might be a disadvantage. Performing induction of labor does allow for an intact fetus after completion. In some cases, that can be helpful if we think that an autopsy might be helpful for providing more information about what was going on with the patient that was diagnosed with a suspected anomaly. Although I will say that our tools for prenatal diagnosis and genetic testing have become quite advanced. So I don't find that it's super critical for most patients, although it certainly is a consideration. And in some places and sometimes at BIDMC, we are able to offer sort of an attempt at an intact dilation and evacuation in certain circumstances, but can never sort of be guaranteed that can be performed. Patients also might have a personal preference for an intact fetus if they are interested in seeing and holding after completion, which is certainly possible with an induction of labor and might allow for more opportunities for memory making if that's important to the patient or the family. And then the other big big advantage, of induction of labor is that it's widely available and it doesn't require any advanced surgical expertise like dilation and evacuation would. Some of the downsides of dilation and evacuation is the need for cervical preparations. That usually happens under local anesthesia, but it can be kind of uncomfortable. And so patients might want to avoid that. Obviously, there are some complications that go along with dilation evacuation and the use of instruments. Those are overall low, so low rates of uterine perforation or injury to other things. And then there are the technical and size limitations with dilation and evacuation. So beyond really kind of that 24th week, at least at BIDMC would not be available. And then the downsides to induction of labor, I think we hit on the longer time to completion and the unpredictability around that. as well as, for some patients being awake or having that experience might be a downside as well. There is a little bit of a higher bleeding risk. Some of the studies have shown with induction of labor, certainly at earlier gestational ages, and then some concern about increased rates of infection, although it's not super clear for the studies if that's sort of more related to medicines or maybe the use of neuraxial anesthesia, if it truly is an increased rate of infection. Overall, that's fairly low. One of the potential risks in induction of labor, which we'll always prepare patients for, is the risk of a retained placenta. Overall, that's low. It depends a little bit on how patient we are in waiting for the placenta after delivery of the fetus, but that rate is about 5 to 10%. So patients may end up needing a surgical procedure for removal of the placenta and maybe have a higher risk of bleeding if that were the case. But again, the bottom line is that, both of these are very safe and effective. The risk of complications is overall very low. And so really try to encourage and empower patients to choose the experience that they feel is going to be the best fit for them. Would you add anything to that, Dr. Dutton?
No, you did a great job.
So I'm going to talk briefly about induced fetal demise. This has a lot of different terms. Some providers would call this a fetal-cidal injection. Sometimes we'll call it a BIDMC, a KCL injection, because that's the medication that we use. But in general, this refers to the injection of a medication either into the fetus or into the amniotic sac to induce fetal asystole or to stop the heartbeat. And this procedure can be performed prior to dilation and evacuation or prior to induction of labor. At BIDMC, for the safety of our patients and also to kind of prevent that very rare complication of potentially having a periviable delivery, we would perform this for surgical procedures that are occurring at 24 weeks or later, and ideally prior to laminaria placement or prior to the start of that surgical procedure. And then for induction of labor, we'd perform this at or after 22 weeks, though it certainly is an option for any patient per their preference at earlier gestational ages if they wanted this beforehand. And then in terms of the procedure itself, it's relatively straightforward. So at BI, we use potassium chloride, and we inject this directly into the heart under ultrasound guidance. We can do this in an ultrasound room or in the operating room if the patient is undergoing dilation and evacuation. It's a very similar technique to an amniocentesis, so very well tolerated by patients. It's a very short procedure and it's immediately effective. There are kind of few reported studies specifically on KCL for intracardiac injections, but very, very low rates of complications in the small studies that are published. So I'm going to return now to the case that we started with and then just walk through a couple of different scenarios and how we would counsel this patient about options depending on gestational age and with an eye to the law in Massachusetts as well. So just to remind everyone, this is the 43-year-old who presented for the first visit and had an ultrasound that showed the fetus measuring about 23 weeks with multiple abnormalities concerning for an underlying genetic condition. So after counseling the patient in this scenario, the patient chooses to undergo diagnostic testing by amniocentesis. So this is performed, a couple of days later, and the preliminary results come back showing trisomy 18. So after counseling about all the options based on this result, the patient wishes to proceed with terminating the pregnancy. And now the gestational age is 24 weeks and 0 days. So for this patient, both dilation and evacuation at exactly that 24-week mark and induction of labor are both options, and induced fetal demise would be performed prior to both of those. So this would be a patient that we would walk through kind of the procedures for, both dilation and evacuation, pros and cons, and help them come up with the best decision for them. And just to remind everyone that at 24 weeks in the state of Massachusetts, both of these options would be available to any patient requesting an abortion, whether or not that's for a fetal diagnosis or any particular indication. So now we're going to change up the scenario a little bit. So in scenario number 2, This patient chooses to undergo diagnostic testing and has an amniocentesis, but the preliminary results come back as normal. So after further counseling, this patient chooses to pursue further workup. So waiting on additional genetic testing and undergoing further evaluation for diagnosis. So you can go to the next slide here. So over the next 2 weeks, the final results of the amniocentesis, the karyotype and microarray return as normal. The patient sent to an advanced imaging center has a fetal MRI that confirms the suspicion for agenesis of the corpus callosum, so a neurological abnormality with kind of a range of potential outcomes. But then the fetal echo and the remainder of the ultrasound are actually normal. So that would be a little unusual given the initial findings, but prenatal diagnosis is not perfect. So agenesis of the corpus callosum is the only finding after additional workup. The patient has counseling with pediatric cardiology who did the echo, pediatric neurology, and MFM, and has a follow-up growth ultrasound about 3 weeks later, because that's how long it's taken everything to get done. So now at 26 weeks and 2 days, the patient kind of faced with this uncertainty about the neurologic condition requests an abortion. And now at this gestational age at 26 weeks, the option for abortion would be induced fetal demise and then proceeding with an induction of labor. So, in a patient like this, where I feel like, additional workup may change the options in terms of procedures for the abortion, and we may no longer be able to offer dilation and evacuation, I'll usually include that in my sort of initial counseling, particularly because, I think there's some preference in some studies, and I would say also anecdotally for some patients who prefer dilation and evacuation. So try to let them know this in advance. And again, this would be available to any patient requesting abortion at 26 weeks. It, again, doesn't have to be for any particular fetal diagnosis in the state of Massachusetts. We're very fortunate that we see most of our patients for their anatomical surveys at about 20 weeks. So usually that allows for ample time for additional workup if there are unexpected findings, and still have options for both dilation, evacuation, and induction of labor. And then in our final scenario, I just changed the initial dating here. So now this patient presents at 26 weeks with an ultrasound again that's concerning for multiple fetal abnormalities. This patient chooses to undergo diagnostic testing at 26 weeks and 5 days, or a couple of days later when you're able to arrange that. And that preliminary FISH result comes back with a diagnosis of trisomy 18. So after counseling on all the options, this patient also chooses to terminate the pregnancy and is now 27 and a half weeks or so. And so the option here again would be induced fetal demise and then induction of labor. And then I think there's just a slide to remind you of the 4 situations where this is available past 26 weeks and 6 days. And that's to preserve the life or physical and mental health of the patient. For lethal fetal diagnosis, which would also often call life-limiting, so that would be trisomy 18, or a very grave fetal diagnosis. And the option for abortion at those gestational ages would be by induction. So I'm going to change topic a little bit here and talk quickly about 2 special populations that we see, especially in the maternal-fetal medicine world, and just talk quickly through options for abortions for twin pregnancies, and then about all the options for life-limiting or lethal fetal diagnoses. So for twins, there are options for termination of 1 or more fetuses in an ongoing pregnancy. And the same laws pertaining to general abortions would still apply for these scenarios. In most cases, this is performed in the same way that we perform induced fetal demise for any other pregnancy, by an intracardiac KCl injection. The one exception to that is monochorionic pregnancies, which I'll talk quickly about. And there are 2 general types of terminations or reductions available in twin pregnancies. One is a multifetal pregnancy reduction. And in this scenario, there's sort of a non-selective reduction of 1 or more fetuses to reduce the total number of fetuses in order to improve the outcome for the pregnancy or per patient preference. And then that's usually performed, kind of earlier on in pregnancy. And then there's also options for selective reduction or termination if a genetic or structural abnormality is encountered or diagnosed later in the pregnancy. And then you can go to the next slide. Just to remind everybody about what ACOG says about multifetal pregnancy reduction. So we should be talking to all triplets or higher order multiple gestations about this option and discussing sort of the benefits in improving perinatal outcome because of the significant reduction that we see in preterm delivery with reducing the number of fetuses. And then in twin pregnancies, ACOG advises to consider discussing reduction to a singleton based on the understanding of the particular patient, the unique medical situation, and that patient's values. But certainly information should be provided on patient request. And there is some data to suggest that reduction for twin pregnancies also improves pregnancy outcome. And then just quickly to mention that there are options for reduction in monochorionic twin pregnancies. In this case, the standard technique for induced fetal demise is not recommended because of the shared circulation in that single placenta. Because of that, there are multiple techniques to perform a reduction, but they tend to be higher risk procedures. And so generally when we're talking about these procedures, our outcome is really to improve the overall outcome for a healthy twin by reducing an anomalous, non-viable, or critically ill fetus. And so the indications for this procedure are going to be a little bit more narrow than dichorionic or higher order multiples. But these might include severe discordant structural anomalies, severe fetal growth restriction, potential complications from twin-twin transfusion sequence, or trap sequence where we have an acardiac twin. And the procedure for this, at least at BIDMC, uses radio frequency ablation that's produced by a generator with a special probe in order to perform cord occlusion at the abdominal cord insertion site. This is a little bit more of an invasive procedure, but only involves a teeny tiny incision on the skin and is generally performed with some sedation for the procedure. So that is an option for monochorionic pregnancies for kind of those select indications. And I'm gonna sort of change topics quickly again to talk quickly about patients who are diagnosed with a suspected life-limiting fetal condition. So here there are a number of options available to patients, of course, including termination or abortion. Patients may also choose to continue with a plan for assessment after birth or potential medical treatment. But another, really good option for some patients is continuation of the pregnancy with a plan for neonatal palliative care. And I included a slide here with a list of sort of the most common life-limiting prenatal conditions that we see. This is certainly not an exhaustive list, but these are generally the type of diagnoses that would fall under that lethal category for abortion after 26 weeks as well. So this includes trisomy 18, trisomy 13, and triploidy. Those are kind of the more common genetic diagnoses. Anencephaly or acrania, alobar holoprosencephaly or giant encephaloceles. These are all really severe brain malformations. Thanatophoric dysplasia or other lethal skeletal dysplasias. These are very rare. Thanatophoric dysplasia is the most common, but these are not felt to be compatible with life due to the severe pulmonary hypoplasia. Inoperable or very severe cardiac lesions may be considered life-limiting. Bilateral renal agenesis, so absence of both kidneys with anhydramnios or lack of fluid. And then limb body wall complex or pentralogy of Cantrell, which are sort of complex multi-organ malformations. And so for patients who may want to continue a pregnancy with a plan for palliative care, I just wanted to let everyone know that sort of comprehensive perinatal palliative care is available at BIDMC. I'm currently working with a wonderful interdisciplinary group of providers. I think we're up to 20 plus now. And this includes providers from maternal-fetal medicine, OBGYN, neonatology, nursing across all these fields, social work, and spiritual care. And our goal through this program is to support patients and families throughout the pregnancy, during the birth process, and also postpartum. To do this, we're working to develop a birth plan with the patient based on their individual preferences or values, working to strengthen communication with and among providers, and then we're able to provide neonatal palliative care on labor and delivery and postpartum so that the infant can remain with the family during that time. This work is super important to me, and I sort of think of it in the same way as providing high quality abortion care, and that it both respects and offers the full spectrum of reproductive choice to patients. I think that's my last slide.
This is my cue. So
okay, great. Before you go, Caryn, I'll just remind everyone, if you have any questions, you can put them in the Q&A box. And as Dr. Dutton is wrapping up and providing all the resources and updates on Mifepristone, I'll start looking on those. Thanks.
Thank you, Dr. Duffy. So we wanted to at least discuss and mention, because this has very much been in the news in the past few months, Mifepristone. We've mentioned it a few times, and I'll explain kind of how it is most commonly used. Mifepristone is the first of 2 medications in the medical abortion regimen. And medication abortion is the most commonly used method in the United States, more than half of all abortions, especially since that large number occur so early in pregnancy. Patients choose medication abortion rather than surgical abortion. It was first approved by the FDA in 2000. Since its approval, there have been many, many high-quality studies demonstrating the safety, and our patient experience has also supported that. However, more recently, there's been some attempts to block Mifepristone from the market. So just to review how it's most commonly used, a dose of Mifepristone is given to the patient, that's the 1 pill here, followed 24 to 48 hours later by 4 tablets of misoprostol. These 2 work together to expel the pregnancy. Mifepristone is a progesterone antagonist. It blocks progesterone at the progesterone receptor. Misoprostol causes small uterine contractions to expel the pregnancy, and has a very high success rate. Most patients are eligible because most patients who are early in pregnancy have this option. It is non-invasive, so if for patients who want to avoid surgery or anesthesia, they may prefer this option. Some patients also want to be at home and have the support of friends or family, and it allows for also, in contrast, a high level of privacy and autonomy. The experience is very much like having a miscarriage at home. And we do have follow-up arranged for each patient to confirm completion. And if they are in the small percentage of patients who have an ongoing pregnancy or continued bleeding that their body hasn't been able to pass the pregnancy or all of the pregnancy tissue on their own, we do offer surgical management in that situation. And so Mifepristone, as you've heard, is FDA approved for this indication for early induced abortion. However, it is used for many other indications very commonly in OBGYN, because we have high quality studies to demonstrate benefit for medical management, for example, of miscarriage or early pregnancy failure. We use the same regimen of Mifepristone and misoprostol, which is much more effective than misoprostol alone, to allow a patient, again, to choose that option instead of having a surgical procedure if they're diagnosed with pregnancy loss early along. We also use it, as we've mentioned, for cervical preparation, approximately 24 hours before either DNE or induction of labor. And so any attempts to ban Mifepristone will also, of course, affect all of these other reasons that we use it. And so what is the most recent status? This has been quite an adventure over the past month or so. The lawsuit that was filed by the anti-abortion advocates, the Alliance for Hippocratic Medicine, was specifically against the FDA. And it challenges the FDA's initial approval of Mifepristone back in 2000, and also the updates in more recent years that have made Mifepristone more accessible. And so the decision from the initial court in the Fifth Circuit was unfavorable. It went to the Court of Appeals, and the Department of Justice then appealed that to the Supreme Court, who now have granted a stay. That means that Mifepristone does remain legal and available for all of these indications while the case proceeds in the Fifth Circuit. And I initially thought that gave us a nice long time to kind of work on how we're going to defend this issue. And just as I was reviewing my updates in the past few days, read that the initial arguments in the Fifth Circuit will happen on May 17th, just in about 3 weeks. So we still, will learn more in the process over the next few months. We have very much been working at BILH to keep lines of communication open with our providers at all sites, with the leadership, with the family planning champions at all those sites. We've been working with pharmacy to make sure we have adequate supplies on hand of both Mifepristone and Misoprostol. We aren't sure, honestly, how this will affect access in Massachusetts if there is a decision that blocks the FDA's initial approval. Our guidance will come from the FDA. The case is not against providers or patients. It really is against the FDA. And so the FDA will make a determination based on the final decision and provide us guidance for ongoing patient care. All right, so we wanted to also, and I'll let you all, take some screenshots of this if helpful, provide resources, how to help your patients, what resources do we have available in Massachusetts. I wanted to direct you to look at the Reproductive Equity Now websites. This is formerly NARAL Massachusetts. They have worked extremely hard to put a fabulous interactive guide together for patients or providers. Patients are able to enter their age, their last menstrual period, and their location, and are provided a list and a map of what clinics and care is available in their area. Also, Planned Parenthood League of Massachusetts, in conjunction with our Department of Public Health, has abortion access coordinators available for assistance with logistics. And this can be really helpful for someone who is farther along in pregnancy, who has limited options, who might have a medical condition that requires care in a hospital rather than in an outpatient setting. And I would encourage those of you, because I've already gotten phone calls and emails about this from colleagues, if you have someone in another state who is seeking care, these access coordinators are available to help anyone seeking care within Massachusetts, which really helps because even though when your friend from residency has a colleague who has a patient who wants to come to Massachusetts, it's helpful. It's tempting to want to help them yourself to navigate the system. There are systems in place. Abortionfighter.org and the National Abortion Federation and Planned Parenthood all have these access coordinators that are in place to help all of these patients now seeking care, potentially outside their state. For referral for patients or for referral, anyone is welcome to call the BIDMC Family Planning Clinic. We are available through our main campus OBGYN clinic number or by email fpintake@bidmc.harvard.edu. In addition, for patients with anomalies or who may need additional counseling or information, we've provided the phone number for our Center for Maternal-Fetal Medicine. This is a much busier list of other types of resources, and I've been fortunate to be able to talk to a wide variety of audiences about abortion care in the past year, stimulated by the Dobbs decision last year, and a lot of lay members and physicians have asked, how can we help? And so I wanted to provide a list of ways that you can learn more. There's a great website, Reproductive Health Access Project, the first link listed, that has great education pieces and protocols available for providers. The patient education pieces of note are often available in multiple languages, both for contraception, miscarriage, and abortion care. Other sites listed for education. There are ways to engage to donate, and how to advocate. And so I encourage you to think about ways in which you could be part of the support, even if you're not involved in abortion care personally. We really appreciate this huge audience we've had for the talk today. We're honored to be asked to provide this update. We hope this has been helpful in terms of learning about what services are available, how to help patients access care, and we look forward to hearing your questions. This is our emails in addition, so please feel free to reach out to either Dr. Duffy or myself with any questions. I'm going to stop sharing my screen. I apologize that we only have 3 minutes left until 6 o'clock, but I think we can probably go over a few minutes with any questions.
Yeah, there was just
thank you so much for that. So I'll close when you guys are done, but so good.
I was just going to ask, hopefully Erica can help us with this one. There was a request to share the slides after, but I think the recording will be posted. So you'll have them at least in that format.
Yes, the recording of this will be posted on BIDMC's YouTube account under the MFM playlist.
Great. And then I'm going to direct this question to Dr. Dutton. This is from Abigail. So how often are you seeing patients experiencing deferred abortion care due to fake pregnancy clinics? And are we doing anything to educate patients about these clinics?
So, I mean, it may be just the population that shows up in my space in my clinic. I don't commonly see this in Massachusetts. In other parts of the country where I've practiced, it very much was a concern and issue. I was just talking to medical students this morning and gave them an example of patients who were actively advised against having an abortion. And in that context, one of the things I'm very passionate about is medical education, and we provide training to all of our HMS students at every site that they rotate through for their OBGYN experience in abortion care. And I engage them in discussion about really no matter what specialty you go into, this is important information to learn about, to know, to be able to access. And when you land in a new community in the future, reach out and find out what resources there are in your setting and be aware of which ones, often on the large billboards with 1-800 pregnant scared, call us, may not be as supportive and offering patients all options. So they do exist in Massachusetts. NARAL, or now Reproductive Equity now, did a secret shopper study several years ago and demonstrated that they are providing misleading and limited information. So it does still exist. Unfortunately, they are not licensed medical facilities. They don't have to adhere to standards set in place for medical practice in Massachusetts and in many other states. The same problem exists. They're hard to prevent. They advertise as counseling centers and don't require that oversight.
I put a link in the chat to the states. So the Attorney General's office has actually done some education, and there's a website that has information about crisis pregnancy centers. And actually in this year's budget, Maura Healy signed off on, I believe it's a $2 million education fund around crisis pregnancy centers. So that's an area of active advocacy. There are several municipalities that are looking into regulation of crisis pregnancy centers. Thus far, there's not very many easy ways because they're not licensed. So that's a very active area of discussion. Well, with that, I will say thank you so much to both of you. Thank you for sharing your expertise and your compassion, and the care that you provide for our patients is truly representative of what we hope to be able to provide, which is full spectrum reproductive choice, regardless of whether it's continuation of a pregnancy with palliative care or abortion when they need it. So grateful to share all of this with you, and please do not hesitate to reach out if we can be helpful. Thanks again to everyone for coming.
Thanks so much.